Good evening, everyone. My name is Jamie Weiner, and I'm the Special Programs Manager here at the Cancer Support Community in Cincinnati. We are one of over 50 affiliates of a national network that provides social and emotional support for anyone impacted by cancer. Thank you for virtually joining us this evening for our prostate education series, Making Well-Informed Management Decisions. This series is offered in partnership with Prostate Cancer International and will take place the last Wednesday of the month from 7 to 8:30 p.m. through the month of October. Tonight's topic is the diagnosis and workup of men with higher risk forms of localized and locally advanced prostate cancer. Here at CSC, we provide healthy lifestyle classes, social opportunities, and educational programs like this one tonight to anyone impacted by cancer. In addition, we offer support and networking groups to give and get support. Our local prostate cancer information group for people living with prostate cancer in Ohio and Kentucky takes place on the second Wednesday of the month from 7 to 9 p.m. over Zoom currently, but we will be starting to welcome people back in person as well very soon. To learn more about our services and find the Zoom links for the group or any of our other programs, please visit our website at mycancersupportcommunity.org or call us at 513-791-4060. Before we get to the main presentation, there are some important housekeeping issues that I need to cover. Everyone has been placed on mute for the duration of the program to cut down on background noise and allow everyone a chance to hear the speaker. Please make sure you are identified correctly for attendance purposes. If your full name does not show up under your picture, please use the chat button on the bottom middle of your screen and choose my name, Jamie Weiner, from the drop-down box to send me your correct name. You may also notice that we are both recording and streaming this program to Facebook Live. We are doing so for future use and to make sure everyone has access to our programs. Please know that your name and face will not be shown in the video, and we will make all possible attempts to maintain privacy. However, we cannot guarantee your privacy will be maintained if you ask a question live of our speaker. If you prefer to have your question asked anonymously, please send it to Georgia Anderson, who is helping us facilitate the questions this evening by using the chat button and choosing her name from the drop-down box. Type your question or information and hit enter. All questions will be saved until the end of the program. If there are any specific concerns throughout the program, please use the chat button to contact me, Jamie Weiner. Now I'd like to introduce Mike Scott from Prostate Cancer International, who is our moderator this evening, to share with you more about Prostate Cancer International and introduce our wonderful speaker, Dr. Eric Klein.
Thank you very much indeed, Jamie. So Prostate Cancer International, like other organizations, has been helping to provide information to patients and their spouses and other family members for many years now. It is our great honor this evening to have Dr. Eric Klein of the Cleveland Clinic to speak to us about the diagnosis and workup of high-risk prostate cancer. I have known Dr. Klein for many years. And he has done his best to keep me on the straight and narrow with regard to facts as opposed to my opinions. I would like to thank him very much for joining us this evening. And you know, we need people to understand this is about the diagnosis, the initial diagnosis of people with advanced localized disease, but it also encompasses the progression of men who may be on active surveillance to a more advanced status. And what can be done to help them fully understand the precision of their diagnosis, and that will be helpful to them in thinking through their opportunities for treatment if they choose to have treatment. So in addition to being a professor at the Cleveland Clinic, Dr. Klein has so many other affiliations after his name that I'm not even going to try and deal with them. But he has been very involved in research into some of the newer tests that have come to market already, or that I think he hopes will come to market in the future. So with that, Dr. Klein, I would ask you to go ahead and give your presentation. Thank you very much for being with us tonight.
Thanks for having me. And relative to your comment, one of the dictums I live by is to never substitute opinion for data. And so I'll try and give you a data-fueled talk and help everybody understand what high-risk prostate cancer is and what tools that we have to evaluate that. And there are a number of new ones now that have made things better in the recent past, and looking forward to the very near future as well. So let me actually turn this into a slideshow. There we go. I'm assuming you can all see my slides. Yes, can somebody confirm that?
Yes, we can, Art.
All right, terrific. So we'll spend some time on this slide for what the definition of high-risk prostate cancer is, because there's not perfect agreement amongst everybody about what it is, although you'll see some themes here. And let me just say at the beginning that only about 10% of newly diagnosed patients present with what we call high or very high-risk prostate cancer. So it is the minority of people. And the reason for that is that PSA is pretty sensitive for detecting early-stage prostate cancer. Let me also say, although I'll have more detail about this, if you start out on active surveillance, if you fit the relatively narrow criteria we use for surveillance of low-grade cancer or favorable intermediate risk cancer, a little bit of 3+4 disease without any other adverse features, it's incredibly rare for that person to progress to high-risk cancer. Incredibly rare for that person to progress to high-risk prostate cancer over the first few years. I guess if left untreated for 10 or 15 years, I've seen that happen. But in the short term, if you're monitored on active surveillance, you won't be in this situation. And we use other triggers, which we'll talk about a little bit, to identify people who are at risk of getting to this stage and treat them before then. So there are a number of different classification systems for high-risk cancer, and we'll start here with the NCCN high-risk prostate cancer. NCCN is the National Comprehensive Cancer Center Network, and that is those are National Cancer Center Institute-funded centers, cancer centers, and each of those sends a representative to this council that once a year looks at every different kind of cancer, including prostate cancer, and based on published data and expert opinion, come out with guidelines. So we're in the era now where we're transitioning from the old tools that we have, which is basically how much cancer is on the biopsy and how aggressive does it look under the microscope as established by the Gleason's grade, to a molecular and an imaging era where we have so much more information that we can glean about the nature of the cancer, that we're in what we call the precision medicine era. And I'll talk about that. So the definitions that we're going to use here are based on the older criteria of the amount of cancer and the grade of the cancer. So for NCCN high-risk prostate cancer, it's any PSA above 20, or any Gleason's grade greater than 8, or a clinical stage of T3A, which means that the cancer extends outside the rind around the prostate, if you think of it like a citrus fruit. So that's high-risk prostate cancer based on NCCN criteria. And then even more aggressive than that is NCCN very high-risk prostate cancer. So that's primary Gleason's pattern 5. So that would be a total Gleason's pattern score of 9 or 10, which accounts for probably just 1 or 2% of newly diagnosed cases. Or a more advanced clinical stage, and what you see here illustrated is if the cancer extends into the 2 glands next to the prostate, the seminal vesicles, or very high volume Gleason's score 8 to 10. So you get the sense here that the more high-grade cancer you have, that puts you in a higher risk category. So the D'Amico high-risk prostate cancer is named after a radiation oncologist at Harvard named Anthony D'Amico, who's made many contributions. And that's pretty similar to the NCCN high-risk and very high-risk cancers. And then there's the European Association of Urology, which is an organization that's very similar to the NCCN that has similar criteria, PSA above 20. They include Gleason's grade greater than 7. So that would be 8 or above. I guess there's no equal sign there, or locally advanced disease. So you get the idea here. It's about tumor volume, it's about PSA, and it's about grade of the cancer. And that's really what defines high-risk cancer, all of those things. So let's talk about the tools that we have that allow us to stage the cancer and understand what the biology is. One that's tried and true and it's been around since the early part of my career is PSA, prostate specific antigen. And in men, the average man who walks into the office with a worrisome PSA, someone over 50 whose primary care physician says your PSA is 5 or 6, go see a urologist. Most of those patients don't have prostate cancer. Most elevations in PSA actually come from non-cancerous prostate enlargement, BPH, or benign prostatic hypertrophy. And we have new ways of sort of sorting through that. And I'll tell you about that in a minute, although I didn't think to put a slide in. If you have cancer, though, higher PSA levels usually mean more aggressive disease. So what do we mean by higher PSA levels? Once you start getting PSA levels greater than 10 to 15, then that usually means you've got a large volume cancer or a higher grade cancer, grade 7 or 8, something like that. There are two exceptions. One is that some very high grade cancers don't make much PSA. They're so what we call dedifferentiated, that their cellular metabolism isn't normal and they don't make much PSA. And then as we move into the molecular era, about 10% of early stage prostate cancer is driven by a gene called SPOP, SPOP. And it turns out that SPOP associated tumors make more PSA than the other kind of tumors that are molecularly defined by something called ERG fusion. And so you can have a higher PSA, but still have organ confined cancer that's curable if it's an SPOP associated tumor. And we're just entering the era now where testing biopsy specimens for these specific molecular defects or changes is going to allow us to better characterize things. Let me get back to a minute, to a new tool for someone who is referred to a urologist with a PSA of 5 or 6 or 7 or 8 or 10 or something like that. PSA by itself, as I've mentioned, doesn't distinguish cancer from non-cancerous prostate growth very well. So there are two tests on the market already, one called the 4K score and the other called the Prostate Health Index, that can help determine if an elevation in PSA is due to cancer. And there are some other urine-based tests. There's the MySeq score from the University of Michigan, and there are 1 or 2 others. But there's a new one that we've developed in Cleveland that I actually think is the best. All the other markers allow us to avoid biopsying patients with an elevated PSA about a third of the time, 30 to 35% of the time, because they're at low suspicion of high-grade cancer. ISO-PSA is this new test that we've developed that is being rolled out commercially now. And it can allow us to avoid prostate biopsy in more than half of patients who have an elevated PSA. And it's a simple blood test that measures PSA and dozens of other related proteins and works a lot better. And so we're able now, when we see a patient in the office with an elevated PSA, unless they have a rock hard prostate that we're certain is prostate cancer, we usually do an ISO-PSA test. That's what we call a reflex before proceeding to biopsy. If their ISO-PSA level puts them at low risk of high-grade cancer, then we do not do a biopsy. But that's PSA. For newly diagnosed patients who are considering active surveillance, let's say you were referred for a PSA of 5 or 6, and one of these reflex tests indicated that you needed a biopsy, and you have a biopsy that shows low-grade cancer, how do you know if you're a good candidate for active surveillance? The first question that I ask myself when I see a newly diagnosed patient with prostate cancer is not what treatment is best for them, but is treatment necessary? And that's very different than the start of my career 30 years ago, when we really believed that every cancer that was detected needed treatment. And in fact, we treated every cancer that we detected. And we overtreated a lot of men who had low-grade cancers. So the challenge is that using standard biopsy techniques, and the old technique that we've used until very recently is transrectal ultrasound-guided biopsy, we know that we often undersampled the prostate, meaning that we knew that there was some other cancer hiding in the prostate, but we didn't have the technology available to help us assess it completely. And there are two kinds of undersampling. One is biopsy undersampling. Did the needle hit the highest grade tumor? And the second kind of undersampling, it's a newer one that we understand now, is what's the true biologic potential of the tumor that's in the prostate. So it turns out that about 15% of low-grade cancers, Gleason's grade 6 cancers or Gleason's grade group 1 cancers that look benign or not very, I don't mean benign, but not aggressive under the microscope. It turns out that about 15% of them actually have molecular changes, molecular features that put them at risk for developing into something that needs to be treated. That's what we call biologic potential. And we just now have tools to understand and identify which tumors those are. So for biopsy undersampling, we have a tool called magnetic resonance scanning of the prostate, which has really revolutionized the way we do biopsies. And what you see here on the bottom here is a graphical illustration of an MR appearance of a prostate in red here. And this little wiggly green box here is a target, an area on the MRI that an expert radiologist said looks suspicious for cancer. And using what's called fusion technology, where we do the transrectal ultrasound and we fuse the image that we get with the MRI with the target marked, we pull up some crosshairs. That's what this target is here. And we can precisely pass our needle, which is what this cylinder is here, right into the target. And that has really revolutionized the way biopsies have been done. So transrectal fusion biopsy has been the standard until very recently. As a field, we're in a paradigm shift now of doing these biopsies transperineally, meaning instead of, we still put the ultrasound probe in the rectum, but instead of passing the needle through the rectum, we pass the needle through the skin between the rectum and the testicles. That is more accurate, and it also virtually eliminates the risk of getting a bacterial infection, a bacterial bloodstream infection, affecting hospitalized patients that make them sick. That's how we get by biopsy undersampling. One of the challenges with MRI is that it does not see all high-grade cancers. It misses about 20% of high-grade cancers. So if you have a very high clinical suspicion of prostate cancer and a negative MRI, you still need a biopsy. We do random biopsies under that circumstance. So let's talk about biological undersampling, and this is what's relatively new, are the use of what are called genomic tests. And there are 4 on the market that you see here that actually allow us to understand something about the biology of the cancer that's not visible even to the most trained pathologists when they look at a biopsy under a microscope using white light. These tests reveal 2 things. One, whether the low-grade cancer that was biopsied actually has molecular features that have given it already the biologic potential to become more aggressive. And 2 is they actually can tell us something about the biology of the whole prostate. For most prostates, not all, but for most, if you have more than one tumor in the prostate and you only sample one, and you do one of these genomic tests, which means sending a piece of the biopsy tissue off to a company to look at the molecular features of the tumor, you can often tell whether or not your biopsy missed higher grade cancers. So that's really helped us identify which patients are really safest for active surveillance. So what these tests predict for, something we call adverse pathology, which are features that are about halfway between the lowest grade cancers that we know don't need treatment and can stay on surveillance, and features of the highest grade cancers that qualify for what I called before high risk and very high risk cancer. So this puts us in the intermediate ground, which is where we want to know. In the absence of these features, surveillance is safe. In the presence of these features, one of 2 things should happen. Either you should get treated or you should be followed incredibly closely to avoid running into the rare circumstance where you develop high risk cancer. So what's adverse pathology that these molecular tests, these genomic tests predict for? It's high-grade cancer, Gleason's grade 4+3. So that's the bad kind of grade 7 cancer. And if it's more than 50% pattern 4, it becomes Gleason's grade group 3. And then disease outside the prostate, which also we know is a sign of aggressiveness. So if you have cancer, as I showed on the first slide, that goes through the rind around the prostate, that's called extraprostatic extension. and that's an indicator of aggressiveness. Invasion of the seminal vesicles, which finds high risk cancer in some of those systems. Cancer in a lymph node, and then something that the pathologist can see under the microscope, but almost no non-expert pathologists pay attention to. It's called cribriform glands, and it's a specific way that the cancer glands look under the microscope, and it takes a very trained pathologist to recognize this. And our pathologist, our primary prostate pathologist clinic, is a man named Jesse McKinney, is in the process of redefining the grading system for prostate cancer that's largely, although not exclusively, based on this cribriform pattern here, and is going to simplify things eventually. In a few years, I think we're going to get to the point where we just have a dichotomous two-tier system of prostate cancer grading. Either you have favorable histology or you have unfavorable histology. If you have favorable histology, you go on surveillance. If it's unfavorable, you need treatment. So these genomic tests can increase our ability over MRI and biopsy alone in correctly predicting the presence of these features, which generally should exclude patients from active surveillance. And that would be true if that's at your initial diagnosis. And it can also be true and useful if you've been on surveillance for a while and you have a repeat biopsy a few years into that, and maybe the biopsy's gone from Gleason's 3+3 to Gleason's 3+4 with 10% pattern 4. And you can't really know whether that means that it's real progression to the point that it needs treatment, or maybe that pattern 4 has been there and was just missed on prior biopsy. These genomic tests, these gene expression tests, can answer that question for us. And we just published a couple of months ago this new data using one of these genomic tests called oncotype. Oncotype was the first of these tests that was widely used and on the market. And it's reported as a GPS score that goes from 0 to 100, actually, although on the axis here, it only goes to 60. The higher your GPS score, the more likely you are to have these features of adverse pathology. And in my opinion, those are patients who need treatment. And this data really shows us that. So here we see the likelihood, just look at this dark blue line here, the likelihood that 20 years after diagnosis that you would get metastatic cancer or die from prostate cancer based on the GPS score. And what you can see is that if your GPS score is below about 25 or so, your risk of getting metastasis and your risk of dying of prostate cancer is very, very low, certainly under about 4%, maybe even 3% for metastatic disease. And your risk of dying is virtually zero. On the other hand, if your score is above 25, 29, 30, something like that, the risk of getting metastasis or dying of prostate cancer goes up. And the higher the score, the more likely those things, or the more at risk you are, I should say, to have that happen. So this really suggests, unlike MRI, which cannot predict what might happen to you 20 years hence, suggests that if you have a low GPS score or a low score on one of the other tests, that starting out on surveillance, it's safe. It doesn't guarantee that you're not going to get to the point where you need treatment, but it's certainly safe. Just having a low score at the beginning means your likelihood of being alive and free of disease 20 years hence is really excellent. And it also says, maybe even more strikingly to me, that if you have a high score, that's a risky tumor. That's a high-risk tumor as defined by molecular features in a new way that's different from all the other high-risk features that I mentioned on the first slide. And this really identifies those cancers that need treatment. And there's some unpublished data now, spearheaded by a radiation oncologist named Dan Spratt, who was at the University of Michigan and is now at University Hospitals here in Cleveland, using another of these molecular tests called the cypher, which pretty much measures the same thing as oncotype. What they measure is the biologic potential of the tumor. And this was from an observational study in Michigan from, I don't know, maybe 100 urologists, 13 different urology practices. And what it showed is that if you started out on surveillance and you had a low Decipher score, that you stayed on surveillance a lot longer than someone who started out with a high Decipher score. What does that mean? You go on surveillance, you have to be rebiopsied in a year. If you started out with a low molecular score, then at a year, it's unlikely that you progress to one of the triggers that I mentioned that would indicate you need treatment. On the other hand, if you have a high decipher score, look how rapidly people fall off surveillance. About 50% of them fall off within a few months. That again suggests that you may not be a good candidate for treatment. And here's the real telling data here. In patients who are on surveillance, who had decipher scores as they started surveillance, who ended up needing treatment or deciding on treatment, if you had a low score, this flat line here indicates that you were virtually 100% likely to be cured, even if you started on surveillance a few years ago, and all of a sudden you decide to be treated because your PSA went up, or you have more cancer on biopsy, or it went from grade 6 to grade 7. On the other hand, if you start with a high decipher score, even if you're treated at the appropriate trigger, your chance of being cured is less. And way out here, I'm sorry, I can't read the y-axis here, excuse me, x-axis. I think it says 30 months, I think. So about 3 years out. At 3 years out, only about 70% of the people who started on surveillance, who had high decipher scores, who were then treated, were actually cured of their cancer. So this is pretty strong data, in addition to the data I showed on the prior slide, that suggests if you have a genomic test here, when you start on surveillance or when you're into it for a year or two, you get really, really good information out of that test that suggests maybe it's safe for you to continue on surveillance, or maybe it's not. So I'm really excited about this, because these are new tools that allow us to look into the biology of prostate cancer and help us make better decisions than only based on MRI and what the pathologist sees under the microscope. So I love this cartoon. Cartoon is a woman going to her pharmacist, and instead of handing him a prescription for a medication, it says, here's my sequence. And what I love about this cartoon is you can see the date on it. It appeared in the New Yorker 21 years ago. 21 years ago, it was science fiction. In 2021, this is not science fiction. And some of you may have sent your saliva off to 23andMe or one of those companies, have it sequenced and to learn what it tells about your ancestry and your health and so forth. We are in the precision medicine era in prostate cancer in ways that we never thought of before. And one of them is using these genomic tests for active surveillance that I think is well established now. There's another side to this, though, that is useful in some men who have high-risk prostate cancer. We're not talking about active surveillance anymore. We're talking about patients who have tumors that need treatment. And that's called germline genetic testing. What I showed you before is somatic tumor testing, so where you take a piece of the tumor and you get a sequence. Germline genetic testing is the DNA that you were born with. It's what you can blame your parents for. So if you have brown eyes and you want to have blue eyes, that's your parents' fault. It's your parents' genes that determined you have brown eyes. And so there's some guidelines on this now where we are suggesting that people who present with these features, which I'll talk about in a minute, send a blood or saliva sample off to a company or a lab, have germline genetic testing done to determine if they were born with a gene that predisposes them to prostate cancer, because that can be informative for their sons or their brothers or their uncles or their nephews. It can be useful. And in fact, if you're a BRCA carrier, which also increases the risk of prostate cancer, it could be beneficial information for defining cancer risk in the women in your family as well. So generally speaking now, if someone presents with high-grade cancer, Gleason's grade 4+3, we recommend germline genetic testing. If you meet one of those definitions for locally advanced cancers at stage C or T3A or B cancer, we generally do it. And there's a move now amongst medical oncologists to test everyone with metastatic disease who presents with metastatic disease, either at diagnosis or progresses to metastatic disease. And again, the reason is that the knowledge gained from doing this sequencing of the DNA you were born with, and it informs a risk assessment for your relatives. But more importantly, perhaps in today's era, there are certain defects in certain genes, BRCA and DNA repair genes, they're called, that determine whether or not, in the right circumstance, if you would be eligible or benefit from using a new class of drugs called PARP inhibitors. If you're on active surveillance, it's really unlikely that this would ever be of relevance to you. But if you start out with a high-risk cancer, grade 8 or above, or high volume grade 7, or invasion of the seminal vesicles, this eligibility for PARP inhibitors could be very relevant to you, because there might come a time, if your cancer progresses and you fail hormone therapy, that you would benefit from a PARP inhibitor. So that's two kinds of genetic testing, two different ways to think about the precision medicine era, where next generation sequencing has really helped us manage prostate cancer. And just in the remaining few minutes before we consider answering questions, there are a couple of other imaging tools that are useful. One is prostate MRI. I've talked about this already. This is a pretty standard radiologic technique where you lie on the scanner. Some of you might have started on surveillance a few years ago, where they put a coil in the rectum to get a better view. Now, with 3T scanners, 3 Tesla scanners, that's no longer necessary. In about 15 or 20 minutes, you can get this high quality image of the prostate. And this is a man who, on the left here, has no evidence of cancer. This darker area on the top of the prostate is the part that sits around the urethra. That's BPH, non-cancerous prostate enlargement. And this whiter area here, which looks to me like a bird in flight in cross-section, with its wings extended. That's the way I think about it. That's called the peripheral zone, where most, but not all, cancers come from. This looks perfectly homogeneous and white and benign. But compare that to this patient over here, who has the same kind of BPH, who has a smaller peripheral zone that also looks bright and white here, except for right here, you'd see this dark spot. And that's what prostate cancer looks like on an MRI. So an MRI helps us do two things. In someone who hasn't been biopsied, it helps us point our needle in the right direction using that fusion technology that I showed earlier. In someone who's on active surveillance, this can allow us to follow a tumor that we can see. So let's say we biopsied this tumor and it came back lesions grade 6, so the lowest grade possible, and it had a favorable genomic score. That's a good candidate for surveillance. But let's say a year or two later, the tumor is a little bigger, and we rebiopsy it, and it's still Gleason 6, or maybe it's got 5% pattern 4, and we don't really know if it has progressed or not. That's where we can do another genomic test. Well, first of all, we can use MRI to rebiopsy the exact same area, and then we can use a genomic test to see if it really has developed molecular features that are necessary for treatment. The other information that this scan gives us is anatomic information that helps us plan surgery. So just outside here, think of this like a citrus fruit cut in half, like an orange with a rind around it. That's this dark area right here. Just outside that is the neurovascular bundle, the nerves that allow for erections. During surgery, we could dissect right in between the rind here and the bundle and save the bundle. Whereas if there's a cancer adjacent to the bundle, sometimes we remove the bundle to be sure that we get all the way around the cancer. And this information on MRI is very useful. So that's MRI. If you're on surveillance, you absolutely should have an MRI. And MRI makes biopsy better. So before I biopsy anybody, again, unless they have a rock hard prostate that I'm really suspicious has cancer, MRI is the new standard of care. And serial MRIs once a year, once every other year, maybe once every third year while you're on surveillance is important. All right. So there's a big debate raging now about whether MRI or genomics are the better test for monitoring patients on active surveillance or qualifying them for surveillance. And so on this slide, I'm just going to show you how I think about this. These are not really competing tests. They're complementary and they give us different information. So the added clinical value of MRI is not about establishing how aggressive the cancer is, but it's about finding the cancer that we want to know about. So it makes biopsy better. On the other hand, genomics reveals the biologic potential of the tumor in ways that I've shown you already are useful to us. MRI is highly operator dependent, meaning you must have an expert radiologist to look at an MRI and find subtle areas. And I can tell you from experience that even at a high-end place like the Cleveland Clinic, there's variability in the ability of our radiologists to correctly see what's on an MRI. On the other hand, genomic testing takes a piece of tissue and sends it to a laboratory to measure an objective laboratory output. It does not require human expertise, and therefore it is less likely to be subjective interpretation and more likely to be correct. Ease of use: if you've had a transrectal biopsy that wasn't MR guided, then in order to have an MRI guided biopsy, you have to have a second biopsy. That's becoming less and less of an issue as we move toward MR guided biopsy in everybody. On the other hand, a genomic test can be measured on the initial biopsy. You need 1 millimeter of tumor on 5 consecutive slices of a slide, of 5 micron slides, which is a nanomillimeter. And you can get a readout that tells you what might happen 20 years from now. That's incredibly powerful. MRI can't do that. And that's what the last box says here. But unlike MRI, genomics can predict what can happen in 20 years. So this is what MRI does. MRI can show you when you're floating on the water that there's a shark nearby, that there's an obvious spot in the prostate that should be sampled, but genomics allows you to see what's under the surface. And if you have this garbage under the surface, that means you have a tumor that has molecular characteristics of high-grade cancer, and you ought to be treated. So that's how they intersect. All right, 2 more imaging studies, and then we'll stop for questions. One is a standard old school technology, a bone scan. A bone scan is a very simple test where a nuclear medicine physician injects a minute amount of radioactive material, it's usually radioactive technetium, into a vein. It circulates in your system for 2 hours, and then you lie under a Geiger counter, and it looks at your entire skeleton. So on the left here in panel A, you see a man who has no evidence of metastatic cancer. But what we look for are dark spots, but we know there are certain areas that are not cancer that look darker than others. So these are the kidneys here because the technetium is excreted in the kidneys. Spine is full of degenerative disease as we get older, and so it looks a little darker. This is the bladder. These are the joints in the pelvis and the knees and the ankles, and this is a pattern that is normal. Compare it, and you don't have to be an expert here to see the difference, to this man over here who has widely metastatic prostate cancer. So if you look at the long bones of the leg, femur, over here, you don't see much uptake in the man who doesn't have cancer, but over here you see many dark spots. And in the ribs here, and in the arm bone, the humerus up here. So this is a man who's got metastatic prostate cancer. Bone scans are only indicated in men with high-risk prostate cancer. They're not indicated in people who are qualified for active surveillance because they have a small amount of low-grade cancer. For men who present with high-risk cancer, we use this to determine the presence of metastasis. And then the last thing that we're all really excited about are new kinds of PET scans, positron emission tomography scans, called PSMA PET. PSMA is a molecule that is expressed by prostate cancer. It was actually cloned by one of our retired scientists at the Cleveland Clinic for testing when he worked at Sloan Kettering back 40 years ago, 35 years ago, when I started my career and actually worked with him in the laboratory. I didn't have anything to do with that project. He did, but it's taken that long to get this to the point where it does 2 things. This is, in a sense, like a bone scan where this radioactive material that is a monoclonal antibody that hones to cancer that expresses PSMA gets injected, and then you have a CT scan and this bone scan like PET scan, and you can see where the cancer is. So again, some normal tissue shows up here. So this is liver, the red things are kidneys, and this is bladder. But all these green dots here, 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 and here, these are lymph nodes that are too small to otherwise be seen on any other imaging. If you had a CT scan, you wouldn't see these. But when you do the PET scan and the CT together, you can see where the lymph nodes are. And so this kind of technology has been available at just a few places, at UCLA and University of California, San Francisco. However, the FDA has just approved a new PET scan, PSMA PET scan that's going to be available across the country in the second half of the year. We expect to have it in Cleveland in late July and probably elsewhere in Ohio as well in late July. And this is going to revolutionize how we stage people because this sees things that are invisible to all other kinds of scans. And I'll give you an anecdote. Last year, I operated on a man who had high-risk prostate cancer. He had an MRI that suggested his cancer was contained in his prostate. He had a bone scan that was negative, showed no cancer. We took out his prostate. PSA never went to zero, which means he still had some cancer in him, despite a pretty favorable pathology report on the prostate. So we repeated the MRI of the pelvis and repeated the bone scan, both negative again. And he had a PET scan, and it turned out he had one spot of cancer in a rib that was missed by all the other cancers. And so he got that rib radiated, and his PSA went to zero. And I have another patient very similar to that who had a lymph node in his chest, just like this man has right here up in the chest behind the heart. And same sort of deal, he was radiated and so forth. So PSMA imaging is going to revolutionize how we stage cancer and understand who really has cancer localized to the prostate and can get away with prostatectomy or radiation alone, and who has more metastatic disease. And the last thing I'll close with, what's really exciting, is that there was just a clinical trial reported using PSMA PET scan linked to a radioactive molecule called lutetium-177 that actually can kill cancer. And what that trial showed was that in men who had failed hormone treatment, whose cancer was progressing, if you treat them, not only image them, but you treat them with PSMA PET linked to lutetium, a lot of the cancer regressed and they actually live longer. And we're all very excited by that, because if you were to use that in someone who had a really minimal amount of metastatic disease like this man does, it's possible that we could cure this patient who has metastatic prostate cancer. And that's remarkable, because in my 30 years of practice, I only know of one patient who had biopsy-proven metastatic prostate cancer who is cured. He's 10 years out from treatment and has no evidence of cancer. So that's the exciting thing that's on the horizon. So that is all the slide data that I have. And I would be happy to take your questions on anything that I've covered or on any other topic related to prostate cancer.
So thank you very much indeed, Dr. Klein. There are a couple of questions I'd like to ask you first, which I think probably are of general importance. You mentioned that approximately 10% of patients are diagnosed pathologically with a high-risk disease. And then I think you said it was about 15% of the remaining patients with lower risk disease might be shown to have genomically identifiable higher risk disease. Is that correct?
Yes, although I would put them in two categories, right? The 10% who are diagnosed with high-risk disease definitely have cancer that needs treatment. The 15% of patients with low-grade cancer who have molecular features that indicate it could turn into the kind of high-risk cancer that needs treatment. It's sort of a transition. It's not so much that it has the same clinical implications as someone who presents with a grade 8 cancer. If you have low-grade cancer with high-risk molecular features, it's not that you necessarily need more aggressive treatment. It's just you need to be treated. You're not a good candidate for surveillance.
Thank you for that clarification. I mean, I think the point I'm trying to make sure that the audience leaves with is that our general impression that if you get prostate cancer, it needs to get treated, which certainly you and I had 25 years ago, has changed radically to one where we actually think something of the order of 80% of men probably can be managed well on active surveillance for a significant period of time.
Probably correct. Not sure it's quite as high as 80%, but certainly more than we're doing currently.
Right. I mean, that's a ballpark number. I'm not trying to be statistically accurate. The second thing I wanted to ask you to talk a little bit about was access to all these new forms of diagnostic tests.
Yes.
Clearly, if I go to UCSF or the Cleveland Clinic or Memorial Sloan Kettering or MD Anderson, those tests will be available to me if my insurance covers them or whatever else. Out in the community, can you give me some idea of the degree to which these tests are starting to be used, or at least even told about to patients?
Yeah, so bone scan is widely available every place. It's very old technology. MRI is widely available also and generally covered by insurance in men who have prostate cancer. Genomic testing is widely available. And in a recent poll of the American Urological Association, 60% of urologists said that they use genomic testing to manage their patients on active surveillance. So that shows you high penetrance. Most urologists know about it, and it's very easy. All it requires is that they establish an account with one of the companies, and they ask the pathologist who has the slides to send a piece of the tumor to the company. So, any community-based urologist can do that. Nothing special. PSMA scanning will be widely available. The company that makes this has contracted with a number of companies around the country that will make the radioactive material to be injected for PSMA scan. That's the limiting factor, because the half-life of that particular reagent is only about an hour or two, I think. And it needs to get into the patient soon after it's created. So you have to be close to a facility that can do it, that can create it. But after having said that, almost any radiology department actually has the equipment to do the actual PET scan and the CT scan. It doesn't require any investment there. It just requires access to this. So there will be a big marketing push when this becomes available now that it's FDA approved. And I suspect urologists will sign on to using it as appropriate.
Do you think that the insurance industry will cover this without too much problem?
Well, at the beginning, there'll be a problem for sure. And the insurance companies will establish strict criteria for who's a candidate for it and who isn't. The FDA label indication means that usually the Medicare will pay for it. If the FDA approves it, Medicare, I think it's required by law to pay for it. But its use would be restricted in patients who are at high risk of having metastatic cancer. So that'll be the patients that I talked about on the first slide, those with high risk or very high risk cancers. PSMA PET scanning is not appropriate for patients who are candidates for active surveillance.
And I had one more question before we open this up to others. I noticed the other day you had published information about a new form of test developed by a company called Grail.
Yes.
That appears to give us a much broader opportunity to assess risk for cancers of multiple types. But
yes,
I think prostate and breast cancer were among the two largest components of that study. Could you talk a little bit about that?
Sure. Cancers shed DNA into the bloodstream, and the technology exists now. It's the same technology called next generation sequencing that was used to sequence the whole genome and what's used for 23andMe. So cancer cells shed DNA into the bloodstream, and it's possible with a single blood test now to find that DNA amongst all the other things that are circulating in our bloodstream. And what this test can do is identify the presence of more than 50 different kinds of cancer. And if you have a signal that suggests you have a cancer present, really remarkably, it can, with 90% accurately, predict what organ it's from. So if you were to have this test and it came back as a signal suggesting you have cancer, the second part of the report says, well, it's highly likely that if this is cancer, it's kidney cancer, go have a CT of your kidneys. Or it's highly likely that it's lung cancer, go have a CT of your lungs, that sort of thing. It doesn't actually, believe it or not, it doesn't perform very well for early stage prostate cancer, nor did it look like it was better than mammography than for very certain kinds of breast cancer, what's called triple negative breast cancer, which is very aggressive. But otherwise it didn't perform very well. But it does perform very well for cancers that we don't have good screening tests for. So the two index cancers that I think of are ovarian and pancreatic cancer. Everybody knows someone who was diagnosed with one of those cancers at an advanced stage and died because they're hard to cure at an advanced stage. This test in the published studies finds about 75% of ovarian cancers and 75% of pancreatic cancers, which really remarkable. And that's going to give us the opportunity to be able to treat those aggressive cancers at a much early stage and kind of turn it into the paradigm that PSA has allowed for prostate cancer. So it's very exciting. Importantly, two other important points about the test. One is that it has a very, very low false positive rate, 0.5% only. And the second thing is it's meant as a supplement to standard screening, not as a replacement. So we still need to get our colonoscopies and mammography and PSAs and that sort of thing. But it's pretty exciting. It is going to revolutionize how we screen for cancer.
Thank you. So perhaps we could open it up now to questions from the rest of the audience. Do we have anybody who wants to ask a question live?
Yes, please. Yes.
What?
Thomas, yes. And please, you've mentioned MRI and then PET scan. What is the difference between PET scan and Tesla scan? Because Tesla scan, MRI, I'm told is about 3 times the power of MRI. So is PET scan much better for the capturing or for the treatment?
MRI gives us detailed information about the prostate itself, anatomic information that can help plan surgery, and anatomic information that tells us there's a worrisome area here, point your needle there. PET scan will be able to tell us if there's cancer in the prostate, but it won't be able to tell us with the same degree of accuracy. So it would be like the difference between saying, if you were to do a PET scan of Ohio, you could point to 3 cities. You could point to Columbus, Cleveland, and Cincinnati as being in Ohio. But if you did an MRI, you'd be able to point to a specific house at a specific address.
Okay.
PET scan also will be better for finding the presence of cancer outside the prostate than MRI will. So again, they're complementary technologies.
What of the Tesla?
The Tesla, the Tesla. So Tesla is a measure of the strength of the magnet of the MRI. So for many years, standard MRI was 1.5 Tesla. And in order to get a good image of the prostate, you had to have a scanner right up against the prostate. And in order to do that, you had to put a probe in the rectum during the scan. When you double the strength of the magnet to 3T or 3 Tesla, you no longer need the probe in the rectum. You can get more information from the prostate itself. So it's more comfortable for the patient. It's actually quicker to do the stronger the magnet.
Could I just interject here, Dr. Klein? My understanding is that we've been using something called Pyrads methodology to assess the value of MRIs, but recently this has been shown to be less than helpful in the sense that there is wide variation between the ways that the MRIs are interpreted.
Yes.
Are people still trying to improve the Pyrads system
Yes.
so that we can solve that problem?
Yes. So the Pyrads system is good to a degree, but you're right. Its correct interpretation depends on the expertise of the radiologist, and that's not uniform across radiologists across the country or even within the same institution. The ways that people are trying to improve that is using artificial intelligence and looking at digitizing the scans and having a computer look for patterns that the human eye can't see, and for the computer to then spit out a report that says this particular area in this particular prostate that's seen on MRI, it's what looks worrisome, even if the radiologist doesn't think that. That's probably not ready for prime time, but that's what's coming. So there might come a time where you can have your MRI done anywhere, and a technician can upload it into a computer, and a computer algorithm will spit back the answer without needing a human to read it.
So what you're saying is that hopefully if we can apply artificial intelligence, and presumably this is another tool that Watson will be able to help us with,
Right.
that you might be able to better objectify the results of the MRI scans.
You might be able to make it as good as Genomics, which is already objective.
Thank you. Another question from the audience. Do we have any questions that have come in online?
I have a question.
Sure. Who's speaking?
This is Mike Scanlon.
Go ahead, Mike.
I had a couple of PSMA tests scans done, one at NIH, the other at Johns Hopkins, is the PYL scans. And
Yes.
they only showed like 3 spots in there. And I know, and Johns Hopkins blasted with radiation didn't do a thing for them. So I went to Mayo and did their C11 choline test and found a lot more cancer.
Yes.
Now, would that mean that this, if I tried another PSMA test like the one with the 177 for treatment or something, would that probably not work, or does different PSMA things work differently on different people?
Yeah, the answer is the latter. Not every cancer expresses PSMA, and so won't be seen by every scan. And so your cancer sounds like it expresses something that's picked up by the other kind of scan that you had, but it doesn't make PSMA. So in order for a PSMA, the PSMA is the homing agent. That's what the antibody is looking to find. If your cancer doesn't express much PSMA, you're probably not going to benefit from a radioactive molecule that's linked to PSMA. But the technology is such that it probably could be linked to the marker that you do express, and you might benefit from that. But it's a little bit more complicated. That's called theranostics. So theranostics combines therapy and diagnostics, although you do the diagnostics first. You're going to benefit from PSMA lutetium. You have to have a plain PSMA scan first and have cancer that shows up for PSMA, and then you'd be a candidate.
My memory from the trials is that it's something like 80% of men with advanced disease do express PSMA.
Yes.
I have a question, please. Could you, doctor, please explain the difference or the interrelationship between mitochondria, sugar, oxygen, the breakdown of food, protein, carbohydrate, and fats?
No, I can't.
In relation to cancer.
You need to talk to a biochemist about that. That's outside of my area of expertise.
Okay.
That I trained as a biochemist, and I can tell you that that is a very, very, very complex series of relationships. And that's from a biochemist who trained nearly 40 years ago. I mean, it is a very, very sophisticated system. Any more questions?
I have a very basic question. This is Andy Heldman.
Yes, Andy.
Yes, I had heard that PSA is proportional to the size or volume of the prostate. And if you have a larger prostate, that your PSA will be proportionally like 1/10 or 10% of that number. I just wanted to see your opinion on that, or if it's
no, it's not a matter of opinion. It's a matter of fact. Normal prostate cells that do not have cancer make PSA. And the more cells you have, the more PSA you'll have in your system. So the bigger your prostate, the more cells you have, the higher your PSA is. So that's why if you have a relatively low level elevation in PSA, 5 or 6 or 7 or 8, it's often usually not reflective of cancer. It's more reflective of prostate size. It's another advantage of MRI because it gives us an accurate size estimation. So if I see a man who's got a PSA of 6 and a 30-gram prostate, that makes me worry because 6 is too high for a 30-gram prostate. If I see a man who has a 100-gram prostate and his PSA of 6, I'm pretty certain that that's not prostate cancer. And so we can calculate another number called PSA density, which is the PSA level in the blood divided by the volume of the prostate. And if you're below 0.15, you're less likely to have prostate cancer. And if you're above 0.15, you probably should have a biopsy.
Dr. Klein, I don't think I've ever asked anybody this.
Thank you.
Can you give us some idea of the ratio of the number of men who get diagnosed with BPH each year relative to prostate cancer?
Yeah, it's huge. I mean, the last number I remember seeing is 50 million men in the US have BPH. And I mean, virtually everybody over age 50. And I don't know what the exact number is in newly diagnosed cases of prostate cancer already for you. It's 120 or 130,000. So it's a huge discrepancy.
Yeah, and I think this is a very important thing for the patient community to understand. I mean, measuring PSA is much more likely to help you find that you've got BPH than it is to help you find you've got prostate cancer. Any more questions? And do we have any? Do we have any questions in the chat?
So we have, it looks like more of a statement. So it says the value of the PSA density number is the PSA divided by the prostate volume. Is that correct?
Yes. So the value is what I just said. If you have no spots on an MRI, nothing worrisome, and a low PSA density, the likelihood of you having a significant cancer is really small. That's how it's useful.
All right, so far that is the only thing I have in the chat.
Well, if we have no other questions, I think Dr. Klein's given us an excellent presentation this evening. Okay. Thank you very much. Hopefully
I do have one more question.
Oh, you do? Go ahead. I'm sorry.
My wife had a question. Okay.
That's very important.
Yes. My wife, I had a Gleason 10. This was 5 years ago. And I had my prostate removed through Da Vinci. And it was, but it looked like the pathology showed it was all contained, and there wasn't any spread. And, you know, she was listening to these scans detecting cancer someplace else. Now, my PSA has been undetectable ever since. So I consider myself a very lucky guy with a Gleason 10 that happened to be that way.
Agreed.
So the fact that my PSA is undetectable, I feel I'm pretty well clear, and we won't need any more of these other scans or anything else to detect anything else.
Is that correct?
Is that correct?
Well, when you have a high-grade cancer, it is possible that it could recur many years later. I mean, the longer you go without cancer, you know, the less likely that is to happen. But we still occasionally see patients with high-grade cancer who don't recur for 20 or 25 or 30 years. And so it is possible that it will come back. The good news there is you've got a great marker, PSA. As long as your PSA remains undetectable, there's no reason to do a scan on it. The other good news is that if your PSA does become detectable, we have better and better diagnostic modalities, as I mentioned, the PSMA-based PET, and every year there are new treatment modalities that come out. So you have every reason to be optimistic about living a normal lifespan and not dying of prostate cancer. But I would just say it's possible that sometime in your long life that you have ahead of you, you might need some additional treatment for your cancer. And so that's okay. If you think about other potentially life-threatening diseases like high blood pressure and diabetes, if those aren't treated, people die from them. But if they're treated and managed appropriately, they live a normal lifespan and they end up dying of something else. And that's what we're getting to the state of the art in prostate cancer, is that same thing.
So, Dr. Klein, I had one last question for you, if
Yes.
you're generous. I know that the AUA has started to look very seriously at changing its guidelines with regard to transperineal biopsy as opposed to transrectal.
Yes.
I'm also well aware it takes a while to learn how to do this really well.
Yes.
But I am curious how long you think it will be before that truly becomes the normal standard of biopsy as opposed to where we are at today.
Yeah, probably another couple of years, 2 to 3 years. Technology exists. There are multiple vendors in the marketplace, and it's getting easier with repetition. When it first started, it was very cumbersome. I've done about 300 myself, and I was just thinking today that that's about the learning curve. It's taken me 300 to get to the point where I have real confidence that I can do it well and efficiently and accurately every time.
Yeah, I was personally quite surprised to hear the other day that one of the Baltimore VA medical centers has already completely switched over to transperineal.
I have two in my practice. I have two in my practice, and my goal is by the end of the year across the whole Cleveland Clinic system to switch over.
Okay, thank you very much indeed. So thank you very
Sure.
much, Dr. Klein, and I'm going to give this back to Jamie now to wrap up. And I hope everybody's enjoyed the presentation this evening.
Well, I've had several more questions come in through the chat box if we still have time to pose those.
Okay.
Because I think we're scheduled until 8:30. Jamie, is that right?
Yes, if we need to go that long.
Okay. All right. So the first question that came in is the genomic marker the same as a molecular marker?
Yeah, genomic markers are molecular markers, but there are other kinds of molecular markers also. There are all sorts of different molecules that can be measured. The genomic markers are really mislabeled. When you say genomic to a scientist, they think of DNA. In reality, what these genomic markers measures is RNA. It's what the DNA makes. But we're lazy and we refer to them as genomic markers. But there are other substances that are molecules that can be measured.
All right, sorry about that. The next question was, can you speak to the potential in the coming years for advances in immunotherapy for effectively treating prostate cancer for Gleason scores lower on the scale, such as a 6 or 7?
Yeah, it's a great question, and I can only speculate. I mean, immunotherapy is a standard part of many cancer treatments for other kinds of cancers. It just hasn't worked very well for prostate cancer yet. And so is it possible that eventually it could? Yes, but we haven't figured it out yet. It's very complicated science.
All right, let's see. The next question is, if we have GL6, should we get a 23andMe and a BRCA test?
Well, I wouldn't do 23andMe because they don't look for the right genes. And BRCA is one of the genes that's looked for. So I would look for, if you have a Gleason 6, you don't need germline genetic testing to look for BRCA unless you have it in your family. If you have a higher grade cancer or a locally advanced cancer or metastatic cancer, then the germline testing is useful.
Okay. And then could you please show the MRI compared to the genomic testing again?
Sure.
And I see those other questions that came in, Phyllis, so we'll make sure we get to those.
Oops, there we go. Let's see. Right here. I've got to switch the. Oh, hang on for a second. Bear with me here. I got to go through all the slides here. There it is.
All right.
Oops, I'm sorry about that.
No worries.
Close that box.
I'm assuming that the person asking that question can actually save that.
Well, you're welcome to share my slides with everybody if you want. You can post them someplace.
Yeah, well, we will be posting your slides as part of the YouTube and Facebook presentations, so they'll be available online.
Okay.
Looks like we have a few more questions. So
Okay.
This gentleman says, in my case, an MRI detected a lesion that was targeted in biopsy, but it was not found to be prostate cancer. However, prostate cancer was found in other biopsy samples. Doesn't this mean that the MRI can miss prostate cancer?
Yeah,
And
absolutely.
secondly, do folks on AS need both MRI and fusion biopsy, even if the MRI didn't spot the prostate cancer?
Yeah, it's great questions and two different questions. So absolutely, yes, MRI can miss biologically significant cancer. In fact, it misses about 20% of biologically significant cancer. So the hope was when MRI came along and was used in active surveillance, that if you had a negative MRI, you could avoid a biopsy. But it turned out that that is not true, and that patients who are on surveillance who have negative MRIs still need biopsies.
All right, let's see.
Now, how frequently they're done is a different issue. We use the biopsy every year. Now that we can better characterize tumors using genomic testing and with MRI, we've spread that out a little bit. Generally don't let people go, I don't anyway, more than 3 years without a biopsy.
All right, looks like our,
Eric, if I might just add to that, I mean, if let's say they had 3 successive 3-year biopsies,
Yes.
would you continue to do it every 3 years?
Yeah, so it depends on the age of the patient and their general medical condition and so forth, and how close together the negative biopsies were. There is some evidence that suggests if you have a negative biopsy at a year, that your likelihood of progressing is pretty low. And what we haven't figured out yet in active surveillance is how to tailor the follow-up in terms of how often to do a PSA and an MR and a biopsy for an individual man based on where they start. So if I have a 75-year-old man who statistically has a 10-year life expectancy, who has 1 millimeter of grade 6 cancer on a biopsy and a negative MRI, that's not someone I'm going to follow very closely and necessarily even biopsy every 3 years. On the other hand, if I have a 55-year-old man who's got 2 or 3 cores of Gleason 6 cancer and has a Pyrads 4 lesion on MRI and a genomic test that's low, that's someone I'm going to follow more closely, because if you miss the progression of his cancer, he has a lot more life to lose. We need better algorithms for prescribing tailored follow-up for individual patients. That's an unmet need.
all right, looks like we've had 3 more questions come in. So first, how does micro ultrasound play compared to MRI and PET scans?
Yeah, that's a great question. So micro ultrasound is meant as an alternative to MRI, not to PET scans. Micro ultrasound only sees what's in the prostate. There is data that suggests in the right hands, meaning an experienced urologist who learns how to read the micro ultrasound, that it might obviate the need for doing MRIs, which would be nice, because then you could have your diagnostic scan and biopsy all in the same sitting by an experienced urologist, instead of having to go to a radiology department and have an MR and someone read it, and then have the urologist have the MR available when they do your biopsy. So there is some early data. Again, though, it requires expertise. So the difference is that with MRI, radiologists read the MRI. With micro ultrasound, the urologist is going to have to learn how to read the MRI. But I'm optimistic about it. There are some of my colleagues who think that it could really eliminate the need for MRI. And so we have a newly purchased micro ultrasound machine, and we'll be addressing this issue in the near future. We are offering it at one of our sites.
And when you do that, are you also giving those people MRIs so that you can cross-reference them?
Yes, we're going to be participating in a clinical trial where there's a randomization, and patients with the same worrisome PSAs will get an MR targeted biopsy, and half the patients, based on coin flip, will get a micro ultrasound targeted biopsy, and we will do that. But there's already some published data that suggests that it's equally good.
Thank you.
All right, so the next question is really a 2-part question. So first, have liquid biopsies replaced the need for saturation biopsies? And so now are we in a phase of just needing targeted biopsies?
Yeah, so great question. And the answer is no. Liquid biopsy has not replaced the need for saturation biopsy. And as somebody else asked, does MRI miss high-grade cancer? The answer is yes. So again, there is published data on this. Doing targeted biopsies alone is not sufficient to find all the cancer in the prostate that might need treatment. So the standard is still targeted biopsy and random biopsies. It doesn't, saturation implies 20 or 30 biopsies. A targeted biopsy plus some random biopsies is usually more like a total of a dozen, something like that. You know, whether you really need 20 or 30 isn't clear.
Okay, I am not seeing any new questions in the chat box. If you all think of anything, please pop those in there and I'll be happy to ask for you.
Okay, well, we'll give people a couple of minutes just to see if there are any more questions. But again, Dr. Klein, thank you so much indeed for giving us your time this evening.
You're welcome.
And, you know, we really appreciate your expertise and help in all of this. Jamie, I'm going to hand this
Yes.
back to you.
Thank you. I want to thank you all for your time this evening, and a big thank you to our presenter today, Dr. Eric Klein. Please join us next month on July 28th at 7 p.m., where Dr. Judd Moll of Duke University will speak about issues facing patients who are or may be progressing after first-line therapy for localized prostate cancer.
And we had several comments pop up in the chat of just thanking you for the great presentation and for the thorough answers that you were able to provide.
Happy to do so. Have a good evening, everyone.